I will, I want to start with one question, something that Eric talked about, that was very enlightening and I think lifted a big weight off of my chest, and I think a lot of parents, when you talk about the danger in seizures. So I think what's so common in the FOXG1 community is this fear. Every time my child has a seizure, are they regressing? My child was doing so well, and I was seeing progression, and then they started having seizures, and now they're not doing as well. We have, the ultimate fear with seizures. So in listening to you and in talking to you, it seems that maybe we're a little bit too scared. So I want to touch on that a little bit more.
Yeah. We as neurologists, right, when someone has a seizure, we at first time you talk to them, it's like, it's a seizure, be careful, et cetera, and you're very concerned about seizures. But then once there's a diagnosis of whether it's FOXG1 or Rett or Dravet or any of these severe epileptic encephalopathies, we know now that you often can't make a person seizure-free, and we know that if you follow the kids, there's not a degeneration over time that if seizures were damaging the brain that you'd expect to see over time. And in the few pathological studies that have been for things like Rett and Dravet, there's no cell loss, there's no neuronal loss that occurs even though these kids are having lots of seizures. So it makes me, and these both can comment too, that for brief, frequent seizures, you don't have to be scared of them. Status epilepticus is a different story. So if the seizure is going on for a really long time, that's something that is an emergency and has to be acted on. But the typical seizures in FOXG1, which are brief and self-limited, they're not hurting the child's brain as far as we know. And this is generally true, and there's some older literature that looks at these developmental encephalopathies and comes to the same conclusion. And so I don't know if you guys want to add to that.
Yeah, I completely confirm.
Yeah.
As I have told you, I educate my patients just to know that it's better to have short seizure better than 4 medication and have a child that's completely sleepy.
Right. Yeah, because I think what we hear a lot in our community is with, every next seizure, it's raise the meds, raise the meds. So, I think this could make us feel a lot better that if our child has a short seizure, then...
Right. And as I said, it's really easy to say that. It's harder for everyone to do it.
Right.
And that is, cognitively and conceptually you say, okay, the seizures aren't hurting, I'm not going to do anything. But it is, to put that into practice becomes work for both parts of the therapeutic relationship, both the doctor and the patient. And so it's hard to do, but it's something that, as you get more experience with this and become more senior, become much more comfortable with doing it.
My feeling is that you don't do, you do something. You take your child in your arms. You don't let him just make a seizure and say, okay, it will go. No, you have to do something, but not medication, and it works, right? Yeah.
So the guidelines, I have them, I call them the 3 T's. It's time it, tummy, tongue. Time it because as a guideline, we say that you might want to use a seizure rescue at 5 minutes, but do you have to? It's a guideline, it's not a rule. The next one is tummy, because tummy is a good place for your child to be. On their tummy or their side, they're less likely to choke or aspirate. And tongue, as Eric was saying, don't worry about their tongue, they're not going to swallow it. There's a 4th T, but it's not essential, is if you can grow a 3rd arm and T-mobile it, that's sometimes useful for us. But those are the issues. But remember, it's the 5-minute thing is a guideline. It's not a rule. You may learn that these go on for 7 minutes and then they stop. And there's a trade-off between do I give him a rescue at 5 minutes and then he's wiped out for the next 2 days, or it's less of an issue if I just let it go and it stops at 7 minutes. But it's hard to find out and where you get comfortable with yourself and your clinicians where you get to that point.
Yeah. I mean, 7 minutes to a parent is a
long
lifetime. Yeah.
A long time to count.
Yeah, absolutely. But, and just to touch, another question based on what you just said, is the postdectal tiredness from the rescue medication, or is it from the seizure?
Well, it could be either,
Right.
So that's something that needs to be figured out. You know, if your child has a 2-minute seizure and then is wiped out for a few hours, right, without a rescue, then it's the seizure. But if they normally bounce right back, and then at 5 minutes you give a rescue and they sleep for the next 6 hours and they're out for the next 2 days, then it's likely the medication. So it's a case-by-case thing to figure out with your child.
Yeah. Are there any questions in the audience? Oh, there goes the hands. If not, I'll ask them all. A lot online, great.
So every time we speak about seizures, I hear doctors telling us, after 2 minutes you should use the rescue medication. Our son actually has seizures for like half an hour, 40 minutes, and we still don't use the rescue medication. We only kind of use it if he stops breathing and turns blue. So the question is really, because the 2 minutes and half an hour, it's like not, it's a big difference. Is it because of the type of seizures or
So type of seizure, so the 2 minutes thing, remember, is based upon everyone with epilepsy. And 2 minutes is used because the vast majority of people who have seizures, their seizures last less than 2 minutes. So if you go into an epilepsy monitoring unit and you measure the duration of seizures of everyone who comes in, not FOXG1, not Dravet, but everyone who comes in, it's 2 minutes is the typical. So you're being told 2 minutes because that's the general thing neurologists say. What we're trying to educate is that in these developmental encephalopathies, the rules are a little different, and you have to think about your child. And so if the child's having a focal seizure, that they're breathing, they're otherwise fine, to let it go could be okay, and that you don't have to do it after 2 minutes.
But if it's going to 30 minutes,
So,
at what point do you say?
well, so if you know it's always going to stop
Yeah.
at 30 or 40 minutes, do you really have to do anything? And the answer is probably no. As
Wow.
long as they're safe, you probably don't have to do anything. You're very courageous. Very few parents would have the courage to watch it through for that long, but you figured out that it's going to stop, and that's what you just want to do. If it's not going to stop, then you want to rescue. The other thing to note is that there's both evidence in animals and also in people that it's thought that the sooner you give a rescue, the more likely it is to stop the seizure. Again, that is mostly in adults with temporal lobe epilepsy or other types of epilepsy. It might also be true in FOXG1, but again, if the seizure is just going to stop on its own, do you need to give a medication? So that's where there's all these different factors that come into play when you do this, and you just have to do what you're most comfortable with. You know your child better than anyone else.
I mean, it's more like a cluster of seizures, right? He has like those shocks and then nothing and a shock and nothing, and
right.
that lasts for like half an hour. He's not like...
Right. So if it's a cluster and it goes on for 40 minutes, it's okay. Again, easy for us to say sitting up here, hard for you to do when you're sitting there.
Oh, hi, I've got a few questions. I hope you don't mind. So my son tends to stop breathing when he's having a seizure. Is that because, or what are the reasons for that? Is that because it's affecting the breathing part of his brain, or is it a tonic seizure? You might not be able to answer that. And the other question is, how well do VNS and ketogenic diet work in FOXG1 kids?
So the first one, right, it's hard to know. You can when a child becomes cyanotic around their lips and in their fingers, right, that's partly because the body's shunting the oxygenated blood to the brain and to the heart to protect itself. So it looks worse than it really is. It could be due to there's lack of respiratory muscle movement because it's a tonic seizure, or theoretically it could be from a brainstem. The brainstem thing's the thing we worry about, because then you worry about a complete cessation of breathing, and that is, SUDEP, the sudden unexplained death in epilepsy, which we have no data for in FOXG1, is thought to be one of the drivers of that is a cessation of respiratory drive. So that would become more concerning. And then the VNS and ketogenic diet is for all these developmental epilepsies can be good. It's definitely worth trying and trying early in the process. VNS is much more variable.
I don't have any patients with VNS.
Yeah, I don't think I have any FOXG1 patients with VNS either. Do you?
I have one.
And
It's one.
Ryan, you want to ask a question from
yeah, we have
our
a few from the
viewers at
virtual
home?
group. Yeah. This one, real quick, I think I know the answer based on the data that you presented, but correct me if I'm wrong, is are seizures always present in a FOXG1 diagnosis? And I think there are some children that do not have seizures.
that is correct.
Okay.
Mhm.
So then, and you also talked about wearable devices and curious about heart rate. I actually put my hand on my son's chest if he has a seizure and his heart is beating through his chest. That's kind of how I best can tell when it stops. How reliable is that? And then are wearables able to monitor that well?
Yeah, so heart rate can be a marker. There are some individuals, the majority, heart rate goes up. There are some who heart rate goes down. There are others who heart doesn't change, but the most heart rate goes up during a seizure. Some of the wearables, like the Empatica watch, uses both heart rate, skin tension, and movement to try to detect seizures. So there are lots of people who are trying to incorporate all these different things into seizure detection. So it's a good thing to think about, and it's something, if you can have the wherewithal to measure in your child during it, and you see that the heart rate goes down after some period, even if he's still out of it, it probably is a good sign that the seizure stopped.
How can you distinguish with movement disorder?
Well, right.
That's
And
No, it's my question.
right. Is it a
I'm
convulsion
gonna ask you,
seizure?
how do you distinguish between movement disorders?
Yeah. How does the wearable know?
No, I don't.
Our children
I
are
don't
moving
know.
so much. It's like it's like convulsion.
Misleading.
Right.
Right. Yeah. Yeah.
So, sorry, was the comment that the movement disorder may trip the wearable?
Well,
Okay.
how does the wearable know the difference between a convulsion and movement disorder? So I think you might be getting, a false sense of information. Yeah.
That's why I said be careful about buying one of these things.
Exactly. Yeah.
So the next question real quick on here, is it okay if we run through just a couple?
We got a couple here. Why don't
Oh.
we do the ones here first?
Sure, sure.
Mm-hmm.
I can wait. All right.
Go for it.
The question I have is, it kind of goes according to what he was saying, that some kids don't have the seizures. My daughter, she's 8 years old, but the question I have is she hasn't had a seizure. She goes annually to get her checks or whatever. The thing me and my wife were worried about is because we see a lot of FOXG1 kids with it. Is it something that could happen later on where she can have these seizures? That's the thing that me and my wife are very concerned about. If you've seen that, like in studies that happen later on.
Yeah, so from the natural history study data, there are a few individuals who had their seizures at a later age. So it is possible. I think, I would say to any FOXG1 family that seizures are always a risk, and that if the longer you haven't had it, the more likely you're not going to have it, but that it's always something that you have to keep your eye out for.
I agree.
And perhaps it's hard to know when you're having an EEG once a year and you're not wearing an EEG at all times, that there could be some seizure activity.
Right.
But if it's not harmful to our children's
Right,
brains, then that is
exactly.
not something we need to
Exactly.
worry so much.
And I would say, and I don't know if you guys agree, that parents know.
Right.
If something's going on, they know. If it's at sleep, they know. Like,
Yeah.
I always make fun of dads. Moms know, dads, But, but it's true. Parents know. And so I think people aren't missing as much as you're worried about. I think they genuinely know.
Just to comment, I'm not, I think a visit with your neurologist on a yearly basis is great. We would recommend that. Not necessarily, just to check in. But if it's to do an EEG just to look because you're curious, I'm not so sure that that's a good use of an EEG.
Right.
I think if the EEG question is what was that? Let's try to capture that spell because it's a new thing. I think it's useful. Just my opinion.
I
Got
agree
it.
with that.
Alina?
My question goes to what you just said. You partially answered it. So how often should we have images done? Like our son is almost 5. He's had 2 EEGs in his lifetime of 24-hour monitoring. and he's had one MRI in the past 3 months for his pituitary gland because he has early onset puberty. So, like, should it be repeated? Should we look at other things? Like, what, how often should we do those?
MRI first, okay. MRI, I would suggest if you have an MRI before 2 years of age, the second one should be after 2 years of age, and after nothing. No, you don't need.
The brain doesn't change.
No, the brain doesn't change.
Right.
Exactly.
And EEG, as Tim just said, there's really no reason for it unless there's an event that you're concerned about. Because as I said, the EEGs might be abnormal. It's likely going to be abnormal, and you shouldn't really necessarily act on that. So it's just, if there's an event of interest, trying to capture that event becomes very useful.
There's been a lot of talk in our parents group about parents knowing their children are having seizures, being completely convinced that their children are having seizures, and then getting an EEG and it's just not picking up. So they go through this length of time not being diagnosed or not being given medicine because they're not picking up. At one point, I was even told that the seizure might have been too deep in Josie's brain to pick it up. So is this something common that you just can't diagnose it by seeing it? You have to see it in the EEG? Mm-hmm.
Epilepsy is a clinical diagnosis. It's,
Right.
It's the story that you tell us, and an EEG is something that's helpful,
Right.
but it's not necessary to make the diagnosis. So if you tell me a story, and a lot of times the story, it's like, I don't know, then maybe it warrants a trial of medicine to see if it makes a difference to what you're seeing. And it's a clinical thing. It's, we can't be sure that we're going to always capture a seizure with the EEG. It's just, it always happens. You bring the child into the epilepsy monitoring unit, they're having daily seizures up to that point, they're in the epilepsy monitoring unit for 24 hours, and they have nothing.
Right. Right.
And then they go home
They
and they
don't
have a seizure
perform.
in the parking lot.
Right. Yeah.
And what Tim said about if they're having a recurrent stereotypic event that you can get a video and someone can look at it and say, yeah, that's likely a seizure, then treat and see what it does, if it changes it. As Nadia said, that there's so many unusual movements that this is where it gets very difficult in FOXG1 is how do you know it's a seizure? How do you know it's a movement disorder? And EEG can be the final answer, but as Tim was saying, it doesn't always, sometimes you're left with, I don't know, and then potentially trying to treat to see if you can alter the frequency of the event to give you evidence one way or the other what it is can be helpful.
The fact that it's always the same movement, repetitive, stereotypes,
Right.
so it's a big argument for epilepsy and not for movement disorder.
Right.
The hardest to diagnose are staring seizures and to figure out if that's really a seizure or not. And one of the things we do is we suggest use a firm touch, a weird touch. I just put my finger in right here, which was weird. But those are the things that normally you respond to. Eric didn't respond. But it's the sort of thing that you would do to try to distinguish, was that a staring seizure or was it just they were having a good thought?
Right.
Yeah, I tell patients to use I tell families to use a water gun. That's, you can spurt someone in the face, doesn't hurt them, and it's startling. So water gun's a good thing to use. Do make a mess, though.
I think siblings will love that one. Permission.
I've already, Kate, did you have a question? You want to go first? Okay, just a quick thing. So I am relearning from you guys today that I don't always have to have seizures disappear. And that's a new thing for me because right now, like Adlai is sleeping all day at school and I think he's being tricky. He doesn't want to work, so he's just pretending to sleep. I think that's going on. But then of course I was like, what is going on? Like, is he having sleep seizures? Because we've caught seizures in sleep for 20 minutes and it looked like nothing. So then I was thinking and theorizing, oh, he must be having seizures in his sleep and then the next day he's just sleeping all day. But then he's 10, turning 11. Is this puberty? Like, it's just so hard to know. So I've been on the residence that cares for him to be like tracking everything. And now I just feel like maybe I need to relax. Like he's okay. Like he's fine. If he wants to sleep all day, let the guy sleep all day. It's fine. But I guess the real boiled down question is, why as parents do we want to treat? I used to think, oh, it's hurting him. He can't learn. Like, but if you're telling me he's not going to die, it's just something, you know, that he's going through, why do we treat?
Well, so, if you're having seizures all the time, that's interfering with brain function, and it's going to have an impact, right? So you can't be having seizures all the time. If a kid's having 50 seizures a day, they're not going to learn because their brain is constantly being interrupted by seizures and then is quiet in this postictal period after it. So there's a balance here, and that's what we're talking about. Is the balance that you want to reach. It's not let just your kid seize, it's come up with a balance with the number of seizures and the potential side effects and the medication where you have the best quality of life. So I don't think any of us would say, don't treat your child's epilepsy. It's the balance that you're going for there. And that's, if there's a take-home point, it's that. There's a balance that you don't have to trace every seizure because each seizure is not hurting. And at the same time, though, you don't want to have so many seizures that they can't function. And then the next thing is safety, right? If your child is walking and they're dropping and hitting their head, that's dangerous, right? So you want to treat for safety purposes too. So those are the reasons to treat. And if they're having, if you get an EEG and they're having tons of subclinical seizures all the time, that also is going to be interfering with the brain's ability to carry out its functions. And so sometimes you have to act on those types of things. But there's that balance that you're trying to go for there.
Sorry, just a quick follow-up. I was shocked at the stat that 60% of our population becomes, it doesn't work. The meds don't work anymore. So I'm kind of wondering, is that happening to him right now? Because he's sleeping all the time. But we're not seeing any turning blue. Nobody there is registering seizure activity. So we are going to go through for a 24-hour sleep study on an EEG. But again, it could show nothing. So I really don't know what else to try. So anyways, if you have ideas, please talk to me later.
Yeah. Mm-hmm.
Our pediatrician recommended L-carnitine as a supplement that we could try giving our daughter just to help her brain make connections quicker. He said it wouldn't hurt with her trying that. So just wanting to know what your thoughts are on that, and if there's anything like that, like supplement-wise, that you guys recommend just to help support brain health.
For me, I do not recommend L-carnitine or any supplement. No.
Yeah, and there's no evidence that any of this works. L-carnitine is not harmful, but there's no evidence that it's going to work. And if the cost becomes a factor, take that into account. But there's no evidence that anything works. So therefore, right, as long as it's not harmful, if you want to try it, sure, but there's no reason to do it.
Isn't it to offset something from Depakote?
I was just going to add, sometimes you might put a patient who's on Depakote on L-carnitine.
For the liver?
Whether or not it really helps is another issue, but it feels like you're doing something. And is that always a reason to do something?
Right. Absolutely.
My son has had 4 EEGs, and because I thought, oh, maybe he's having seizures, but it turns out he was having the movement disorders, the stereotypies, and so he's no seizures, 4 years old, but what they've said at all 4, even including the overnight one at the hospital, is he has slow brain waves. And I'm just curious, and they say it's just his intellectual disability, like it's a thing. I'm curious, what else do you guys find out from EEGs? Like, are there other things you can find out, like ways to track, like if kids are taking a clinical trial, like can we learn some kind of improvement?
Right, so that we're doing research on that, right? And the foundation wants to support further research on it. And when you guys did the citizen thing, you gave access to the EEG so that there's ability to start to ask questions about what can be garnered from the EEG beyond are they seizing, is it abnormal? Because the is it abnormal question is going to be yes for pretty much everybody. The abnormality is going to be slowing of the EEG is going to be consistent amongst pretty much everybody. And then there could be what we call epileptiform activity or spikes or sharps. And these are little transients that tell you that the brain is primed to have a seizure. It doesn't mean the brain is having a seizure, but it's primed to have a seizure. And those are all the things that we can.
Because mine has been he's been the opposite. They're like, no, he's not.
He's just slow.
It's just
Yeah.
slow,
Yeah.
which I'm like, okay, that doesn't feel good necessarily. Like, how shouldn't it? So
Right. Well, but as they said, I agree that it's telling you that there's an underlying pathology or encephalopathy where the brain's not functioning properly. But you knew that without an EEG, right? So.
And we've been talking a little bit about the danger of overtreating. So, I mean, how dangerous is that? How much more dangerous maybe is the medicine than the seizure?
Yeah, so, long term, probably not, and we don't know. Short term, though, right, if you're sedated all the time, and if you're, most of these medications, they act on the brain, they slow the brain down. So they have a cognitive impact on the brain. And like I said in one of the slides, some of the newer medications are less cognitively impacting, but things like Depakote and phenobarbital and Dilantin, they, slow you down. They make it slower to do things, slower to respond, and probably lower your IQ when you're on them. When you come off of them, you go back to yourself.
And maybe your blood count too, Depakote.
Right,
Yeah.
right, yes. So they all have potential side effects, right? So, if you're on 4 medications, you're not going to be your best self, right? You're going to be slowed by it. So that's where the balance comes in.
And I'm
So
sorry.
I was going to say, we have a question in the back, and there's 5 minutes left. Maybe we could do rapid fire, because I think there's a lot left, and
sure.
there's several in the queue.
Go ahead.
Mine'll be a quick question. So when you were showing the MRI images, you were talking about how these were mostly in very young children. What is the earliest imaging that you have as far as like a FOXG1 diagnosis? Do you have any images of kids? Like how young was the youngest one? That's my question.
We have prenatal MRIs.
I was going to say we have a prenatal MRI that showed
so
that when you said the corpus callosum
exactly.
issue. Okay, so I was just interested to know like how helpful is that, and then the research that goes to help us treat this.
Yes, this is definitely extremely important to have these images because we want to know the natural history of the patient. So it's important.
Can I ask a quick one? We recently started seeing a movement specialist for the first time. My daughter's movements have gotten to the point where it's not only dangerous to her, but it's dangerous to us as caregivers. And my doctor specifically asked me to ask you guys, what is a good medication to help with her movements? Because we've trialed 2 with no luck so far. I think from what I understood, you're not really finding anything that's really working well for foxes.
No, none work. I try usually clonidine, tetrabenazine, and if it doesn't work, I stop.
Okay, what was that last one?
Tetrabenazine.
Okay, I think that's the one she wanted to try next.
One thing I want to mention is that the resources that they provided today will be on the resources page on our website. So we'll make sure that you didn't have to write down all those notes of all those websites.
Do you use, how much benzodiazepines do you try for the movement disorder?
Never.
Yeah.
And so we'll try a benzodiazepine sometimes, but it usually ends up just being too sleepy and doesn't work, so we just stop it.
And as far as data on medication specifically for FOXG1, like Eric said, we don't have that data. We haven't done a clinical trial for FOXG1 yet, but we are now. So we're going to be doing this trial it's called Fintempla. So we will have data from a clinical trial on one epilepsy med, and hopefully it's effective. We've seen really good results so far for Dravet syndrome, so we're hopeful that this will be a good one.
One more from virtual land, and then
Okay.
we probably need to wrap. If a child presents with increased seizures, when do you know that you should increase the medications, or maybe it's something else that's resulting in the increase of seizures?
That's a difficult one because that's why it's important to use something like seizure tracker. Did the seizures really get worse, or is this just the natural fluctuation of her epilepsy? And again, I think it's a personal thing. It's like, well, are we going to ride this one out, or is it to the point where we have concerns about her safety? And so then you work with your clinician to decide. But again, if, like Eric was saying, sometimes you call the neurologist and they put you on another medicine, and then you just kind of compound where you could be at. And I think that was really something really interesting from Ellie's data, is that a lot of children were on multiple medications, which is something that I think should be avoided if you can. Whenever you start a medicine, you need to have a plan to how you're going to come off of it.
Yeah. See, I told you we could do this all day, so we're going to have to do this one again. And we are going to be implementing Seizure Tracker into our patient data center, so that will give us a tool to really track so that you could see over the long term. So it's not just telling your neurologist, well, the last 2 weeks, this is what happened. You can look over the past 3 months and year and really see. So thank you so much to our incredible neurology team.